what I'd like to do today is give a kind of an overview of disparities, and then funnel down into some of the more recent findings that we've had from this 25-year review or audit of diabetes. So I'll talk a little bit about what we mean by disparities. Are there any interventions? I mean, at the end of the day, it's not about describing disparities, differences. It's about what can we do about them. And I think that's really been the key driver for the Trust for the whole time, and for what we do as health professionals. That's what we do, isn't it? And also the community also puts itself into place to again, try to address things. And then I'll talk a little bit about what's going on in Aotearoa New Zealand overall, and a little bit of data from the metro region, and then in south and west, rather than not really central. And then some conclusions. But just to remind you, I'm sure you all know that, COVID is still around, kind of. And it's a big pandemic. Have any of you heard of that? Well, there was a bigger one before. There was a bigger one during, and there's a bigger one afterwards. But, you're all the converted, which is why you're here. But just to remind you, there is this pandemic. It kills a lot more people than COVID did and has. It costs a lot more, and it causes more harm. But it's kind of silent, and that perhaps reflects the disparities. I was talking with John before about cancer and different conditions. Well, most of those conditions, actually, their effect on quality of life, on QALYs, on these DALYs, disability adjusted life years, their impacts are actually diminishing for an individual as the treatments get better. But there are two things in particular aren't. One of which is dementia, as the world changes and some other things happened, but diabetes still grows. So diabetes is the big pandemic that needs to be dealt with, and yet it's silent. So one of the questions is, why are there these global differences in complications, for example, that we see, and in the prevalence? And there is a difference in prevalence, and particularly age at onset, which I'll come back to. There are things around the management of glucose, but it's not just about glucose. Glucose clusters with blood pressure, blood fats, all these other things. There's a whole range of biology that we're trying to understand, not only for medications, but for things that we need to do and to try to explain and dissect out how much of this is because of disparities and how much of this is biological, but we learn more and more about the genetics and the metabolism and the systems. And there are social determinants, including disparities, that also impact on what is taken up and what people have access to and how effective it is. And fortunately for this talk, John, there's actually a review, Social Determinants of Health and Diabetes, just very recently in 2021. So I'll take you a little bit around that because I think it provides a very good framework for disparities. So there's the overall social determinants, and there's a lot of words, but it's the health and conditions in which people were born, grow, live, work, and age, and they're shaped by a whole range of issues around power and money and resources, and they're mostly responsible for health inequities, which is where it's unfair and avoidable differences. So things that are biological, we still try to deal with, but there are other things which are certainly avoidable, and we need to think about those. And then when we take to health disparities, those are those that are closely linked with social, economic, and environmental disadvantages. The environmental is bubbling up more and more, currently in particular. And they adversely affect groups of people who've systematically experienced greater obstacles to health, whether that be ethnicity or gender, and so forth. So there's a couple of frameworks that you can use. There's the World Health Organization one. Healthy People is a US one. But they come across a number of different aspects, which I'm sure you're all aware of. There's socioeconomic status, which is education, income, occupation. This is obviously summarized. Neighborhood and physical environment, so housing. Built environment. I'm not going to talk about toxic environment exposures, but it's important, particularly in some places. The food environment, so food security, food access, food availability, and I will comment on that. And then healthcare, which of course, this is an American review, and I don't know how relevant the US system is here. I suspect personally not a huge amount. And then there's the social context, which is particularly important. We're talking on a marae, and that's particularly important for Maori, but it's important for all people, whether you be from different Pacific Islands, whether you be from South Asia, wherever you're from. It's very important for us all because we're all human. So the first thing talking about was socioeconomic status and diabetes interventions. And there's lots of studies, and I'm sure you'd expect linking socioeconomic status, whichever way you want to measure it, and diabetes and its complications. People who have a lower socioeconomic index, they are more likely to get the diabetes, they're more likely to get the complications, and that is very clear. But it's actually a bit more complicated, as always. And I'm going to stand on this side. Am I allowed to do that? Past the black dot on the floor. So I moved from the black dot because, but it's quite complicated. So you'd have thought, and this is an example, it's the only reason I put it up, long working hours, that's going to impact on people, isn't it? Yeah? So this is a study looking at the risk of developing type 2 diabetes and long working hours. But actually, and this is called a forest plot, so you'll see a few of these, and down the middle means everything's the same, doesn't matter what you do. This side in this is decreased risk of diabetes, and over here is increased risk. And you can see that whether you've been followed up for less than 5 years, more than 5 years, wherever you are, this is from a global study, whether you're male or female, whatever your age, actually your hours, there's no difference between them in the impact on the risk of type 2 diabetes. There's one group that long hours increases the chance of developing type 2 diabetes. And that's down here, and that's those with a low socioeconomic status. So it's very special. When you're looking at things, you think, yeah, that's going to cause something. Actually, sometimes it's subgroups that are particularly affected. And for long hours, the risk of diabetes increased if you are someone who's got lower income and so forth. So it's just quite important that actually these things are a bit more complicated than we think. And I think that's a really important message. There you go. It even comes up in red just to show you. You can imagine, how do you do a randomized trial of education, income, or occupation? So Kate, I'm going to randomize you to being unemployed. It's very hard to do these kinds of trials. You have to look at it observational. When you do observation studies, quite often they kind of mislead you. But you can do things in terms of literacy, for example, how you provide different materials and how you support people in understanding, their condition and so forth. So this is, I think, a very useful, it's called a meta-analysis, where you put all of the studies together. And this is looking at education, self-management education, where they've considered health literacy. And again, if you look at everybody, and this is all the studies across the world, there's not many, are there? You thought there'd be more of these. You can see that, that when you do this kind of self-management education with special tailored to health literacy, across everybody, it has a teeny effect, 2 millimole per mole. You all know HbA1c. Hands up if you do. Hands up if you don't. Okay. Hands up if you don't want to put your hand up. No, I know. So the HbA1c is the glucose sticking to red cells. Red cells live on average for 3 months. And essentially it correlates with complications. So a 1% or 11 millimole per mole reduction would reduce complications in type 2 diabetes by 20%. So 2 millimole per mole is not really very much, is it? Really, it's quite teeny. But if you take those studies in those with low health literacy, then they do have an effect. So they reduce, as that would reduce with these health literacy appropriate materials, you'd reduce complications by about 10%. So that's quite important. So, yeah. Yeah.
And that's a very American framing of health literacy in terms of a patient deficit. And so in Hoturoa, we talk about the low knowledge.
Okay.
Health literacy. We talk about low diabetes knowledge.
Okay.
It's an important framing.
Yes.
Of health literacy. literacy.
Yes.
Which is very much blame the patient. And
Yes. Yes, it's an American systematic review, but in fact, low knowledge and low health literacy they're two different things from a functional point of view. Because one is how you deliver and one is the actual knowledge itself. So they're two different things.
Think about it from a system perspective and a service improvement perspective and the role, as you say, of the health professionals, but it's never going to be solved by information pamphlets alone. It's going to be solved by...
No, these weren't just pamphlets. There was a whole group education. I didn't put that because I've only got, give me 3 hours and I can get even more in, I can pack it in. Yeah, we can send you a copy of the review and you can see, because I'm summarizing it. So this is within the review on housing. And the association of housing instability being associated with more likelihood to self-report having to go to the emergency department or hospitalization, high outpatient utilization, which is, I don't know if that's a negative or a positive, but I think it's being framed as a negative. And then homelessness is a much higher chance of having, high glucose. But housing intervention studies, again, they're very difficult to do. There was actually one in 2011. And where there was one, it was associated when they had people who were more likely to actually be provided with housing. That was associated with a reduction in the proportion of people with, an increase in the proportion of people with a glucose, which was much more likely to be in the target range. So, they do have an effect, but these are really hard to show. The built environment, we know from observational studies that it's related to physical activity and obesity. We know that from the observational studies, and it's used in urban planning now. But doing intervention studies, again, randomized trials, which is the way that we neutralize, random effects or biases, they can't really be done. They're very difficult, again. So I do want to talk about the food environment. Because I think that's important. I won't talk about healthcare from America, so I'm taking your brief about trying to avoid the American stuff, but there's not that many studies, that's the point. And I will talk. Yeah. So I know this is from my colleague Kathy True, who's at the George Institute, and I don't know how many of you have heard about the Food is Medicine program. Hand up if you have. Good. So I'll just talk a little bit about this because I think it's kind of moving towards some things that we can do, some things we can't do. So, and it's very useful. So this one, particularly around food insecurity, and it's associated with poorer health. So food insecurity, difficulty in affording or accessing foods. The prevalence, and this is in Australia, is about 4 to 13% in the general population in Australia. It's 20 to 30% in Aboriginal and Torres Strait Islander groups. Maybe you've got the numbers for Maori and Pacific people around food insecurity. I don't have that data. And they thought that maybe it's now higher. This is the George Institute. And there's different pathways. So there's nutritional, compensatory, and then it also has its effect on mental health hazards. So you probably can't see this from the back. I can hardly see it here. So, fruit, vegetable sized portions being less, more chance of energy dense foods, less micronutrients, which you always have to think about. And then not particularly necessarily a scheduled food pattern, and scarcity and abundance of availability of many of the foods being associated. This is kind of the model that they're using. And there are different ways of approaching these needs. One of which is, and this is the food as a medicine approach, so all the way from population level healthy food policies and programs, whether you talk about sugar taxes and SSB type taxes. So they're kind of the population level. Nutrition security programs, that's an American type approach. But produce prescription programs, medically tailored groceries, and medically tailored meals. So we do have trials of these going on at the moment, and it integrates food-based nutrition programs into healthcare. I don't know whether these will be paid for by the taxpayer, probably not in Australia, and it can be related for prevention or treatment of diet-related conditions, and they vary in intensity and design. So in the States, there's a lot of these now. because the health insurance companies, which of course is the way that the American system works, they realize and appreciate that this is actually quite useful for avoiding harm and therefore reducing health costs, which is of course what drives those insurance companies. So there have been a range of studies and the systematic review. So these kind of food is medicine. And I'll give you an example of one we've got at the moment, which I think is pretty good. So looking for people with an HbA1c above or out, it started off at around 64, so higher glucose, and people who were identified as having difficulty getting out of the house or getting access to healthy food in one way or another. And then they're randomized to either having their food delivered 3 times a day in packages. So, and they get that from local produce, and they're tailored to that individual with a dietitian assessment, or they get $75 3 times, every 2 months, at the beginning, in the middle, and at the end. So for coming into this trial, you've got a choice of either free food or $225 for free. And so I thought that's quite a good trial in lots of ways. And so we're just coming to the end of that one, and we have others as well which are being set up. So it's associated with a reduction in BMI, reduction in HbA1c, but there's need for more robust randomized trials, which is why we're doing that. More recent studies show a reduction in food insecurity, increase in fruit and veg intake, and again, even more, not just on BMI and HbA1c, but also blood pressure. And for those with diabetes, reduced hypoglycemia events and hospital readmissions. So it's quite a useful strategy, testing to see, well, should this be part of the system? And the insurance companies have already taken up. Do you think governments will take that one up? I thought probably not. So I'll give you another one. So this is built upon work here in South Auckland, and Trish was part of that, weren't you, Trish, hiding behind the camera person? The church program here, with the SDA and yeah. So we had a whole program in which we were working with the churches here in South Auckland, and then had one working with Tainui and Ngāti Tūwharetoa when I was in Hamilton, in the Waikato. So we had that and developed with the Kamātua, and we co-developed a program. And then been tested elsewhere. And so we've just taken this now, and now that I'm in Sydney, we've piloted again through the church partnership program. One was through the marae, this one's through the churches. And it involves community activation, peer support, and healthcare professional support. And so this is the pilot. We've been funded to go through to work with 48 churches now across Sydney, across different communities, which we're halfway through recruitment in. So this is Latoa Afua Diabetes, which is the New Dawn. And this is the structure. So we have a Pacifica community reference groups. This is a partnership group. We have community activators, which are essentially like health promotion officers, but they help. They could be a health worker, marae could be a health worker. Then we have volunteers within the churches. As you know, people want to help their community. That is what community people want to do. That is part of our lives, isn't it? Whether it be our whānau or wider. And then, within churches themselves, what are the foods on display or offered when there's a feast? And this may resonate with some people, obviously does. And, we want to make sure that we link people in. We know in Sydney, I don't know how much here anymore, but there are a lot of Pacific people who do not go to GPs for a whole range of reasons. They don't go. And so this is sometimes the only way in which they're going to have the health screening, which is what you were talking about. So the framework, and I won't go this in detail. So obviously we have the church, we have the homes, and we have the community spaces. We've developed some food access strategies where people can get cheaper fruit and veg from local producers instead of having to go to, in Australia's, Coles and Woolworths. And we have some other things to support people. And we have different ways of approaching the practical upskilling. Remember these, Trish? The cooking classes, walking groups, peer support. And other support. So we have this whole framework in this pilot, which we're now taking to these 48 churches. And the impacts, when we came to this, and these are 3 churches, we did have a 4th one, but they'd lost their building, so they couldn't be in. It's real life, this, isn't it? It's a real, So 32% had diabetes, so a third of the adult population diabetes, 13% of whom, so a third of them were undiagnosed. And this is now all published. 96% were overweight and obese, which again is pretty standard for Pacific communities. And we know there's a whole range of factors around that. So we had 3/4 of the church attendees signed up. 19% completed the training to deliver the program. So we actually said to people, who wants to be a peer support facilitator? And half of them put up their hands and said, we would like to be a peer support facilitator, half. And in the end, we were able to train 19%. People sometimes say, and then they don't, and life gets in the way. So 110 activities were delivered over the initial 12 months. In fact, it was a 4 to 8 month program. And you can see, so the H1C dropped from 46 to 42 across the whole church. So the blood pressure was non-significantly down, almost significant for the diastolic. And you can see here, oh, that's interesting, it's different to this. The physical activity doubled. Cutting the fat off the meat almost doubled, and increased cutting the fat off the chicken. And here's a picture of the walking group. Here they are preparing things in the church, and there's some of the team. And for those with diabetes, their H1C dropped from 65 to 57. And those with new diabetes, theirs obviously dropped as well, but some of them went to see their GP, and I suspect some didn't. So the community feedback, I think, is important. The program is really good. That's nice, especially the food and drinks workshops. The bottles you gave us, I always fill it out and put it in the fridge. When my kids ask for juice, I say, no, drink water. I want my kids to be healthy and eat healthy. And it's built around 12 messages like, drink water, usual sort of things. There is a big difference, especially in our church and family. Before we bring food, too many meat inside and fizzy drink too much. But we've changed to a light lunch and put more vegetables. And I thought we had the picture of the food. I'll just go up there. And this is just what happened in the church. So this was what was happening in the community with the feasts. And this is what happens now. Pretty strong message for people in the community. So I want to talk about the social context and diabetes. Social capital, which is the social structures that serve as resources for us all working together. So that's about trust. And are people wanting to, do things for each other and how we help each other. And they're impacted on particularly by racism and discrimination and who's included and who's excluded. And those are things which are really important for how your community works. And I can see that all resonates. Social cohesion is the extent of how well the community is connected. So I think it's very apt that here we are on a marae, and solidarity among groups in a community. And it's a way of reducing inequalities and patterns of social exclusion and strengthening social relationships and interactions. And then there's social support. So formal, informal relationships, so emotional support, tangible support, informational support, companionship. And these are important, not just because of what they are, and I'll comment on that. So again, this is American. And if you're in the top exposure to everyday racism, they've got a 31% increased risk of diabetes. Women with the highest exposure to lifetime racism had a 16% increased risk, but both of those associations were mediated through BMI. Interventions for these are theoretically different. And in this review, they said, oh, look, they're just difficult. Well, we had a lot of peer support here. There's peer support all over the world. There's randomized trials of peer support, but they kind of missed that. But the peer support, you can see from that church program just how important it can be, where you strengthen people's relationships within the church, to people helping each other. So I would really flag that as something really a major concept that we should have. And then it's not just about each other, it's also about how we structure things. And some of you will have seen this from Sherry Hotu. Have any of you seen this? Hands up if you have. You guys have? Okay. So Sherry Hotu is an endocrinologist from Gisborne. I don't know her iwi actually, but so she had a randomized trial with there's some nurses, but they were supported by healthcare assistants with Marae and Pacific patients. So basically, Marae and Pacific community health workers. And the impact of that intervention, and they had basically a protocol for how to increase the blood pressure medication. And as you know, I can come along and I say to, who should I pick on this time? I'll pick on Kate again. I'll pick on you, Ruby. How about that? So I might say to Ruby, look, Ruby, you really need to take these blood pressure tablets. And are you going to take them? Not. Okay. So, however, when someone who's more peer-like, someone who's from your community and you're more likely to trust than us lowly health professionals, then you're more likely to take those tablets. And there are actually randomized trials of peer support versus nurses, for example. Some of these are from the States. And people are more likely to actually get better self-management when they've got a peer than perhaps they have when someone who's a health professional doing their job. So, and that's not a criticism, it's just the way it is. It's the way it works, yeah. So, but you can see not only did the blood pressure go down, but their protein in their urine as a marker of the kidney damage also went down. So there's lots of these interventions when you put things into that social context that can be successful. And the question is, how do you structure your services? How do you do these things in a way that will work, but still has, you know, all of the benefits and supports that it needs? So how about disparities here? And I live in Sydney, so don't shoot me. You know, that's so, but I did get access to Health Status Report 2023. Who's read that from cover to cover? Wow, no one. It's 2023. All right. So I might have read it more than you. So, and as you were saying, we're looking for a strength-based perspective. And so there's an important part of the report about, and you all know about my reviews on health, so I won't comment on those around Wairua, Heningaro, Tinana and Whānau. And we've already had Karakia. But many of you will have heard of the Te Kupanga survey, which is looking at, from a Māori perspective, statistics on Wairua-tanga, Te Kango, Te Reo Māori and Whanangataranga. So when one looks at those, I don't know whether you've seen this, Robert. Have you seen this? You live it. So this is a survey of more than just one, I hope. Well, it could be. No, it's 86%, so it's everyone except their arm. So 86% of Māori know their iwi. 18% speak Te Reo Māori fairly well or very well, and this varied by region from between 12% in Canterbury and 35% in Gisborne. So 3 out of the 4 Māori reported that their whānau was doing well. 3 out of 4 Māori. The 4, that's interesting. 76% of Māori found it easy to access whānau support in times of need. So here's that support. Being involved in Māori culture was important to 90%, and spirituality was important to 81%. And almost all Māori had been to, 97% had been to a marae at some time, with half being to one in the previous 12 months. And 2 out of 3 knew their marae te puna, and of these, 84% had visited it. And 1 in 8 Māori had participated in traditional healing or massage in the previous 12 months. So this is all part of that social context. So that's obviously, you know, I think, was reported as being strong within that report. But of course, there are other disparities as well that we're looking at. So one of the ones that people don't talk about is around the gender side and life expectancy. So this is the females and this is males, and we men, we die younger. Did you know that? I'll put that one. Who knew that? I won't ask who didn't know that. Okay. And so here's life expectancy at birth. And here you can see up here is Asians have got the highest life expectancy, and then European the other and the total, and then here's Pacific and here's Māori. And that's important because when one interprets diabetes data, we have to always remember that people with diabetes are part of the community, part of iwi. And so, you know, what's happening has to be seen within that context. So we always have to think that. But also there are regional differences. And here's northern, including, you know, Tamaki Makaurau. And you can see that this is the proportion of the eligible population that has their CVD risk assessed. And I think it's important because actually the northern side's doing pretty well, Marae, Pacific, Asian, European, and it's around 90% for everyone. So I think that's actually pretty good when you compare it with Central. And then there's other parts of New Zealand. And then this is the estimated rate nationally of diabetes per 1,000. And you can see here, highest risk is in Pacific people and then Indians. And Marae are actually in between Pacific Indian people and New Zealand Europeans. So this is the overarching aspect, and we need to understand why are there these differences. So I'd like to thank Wing Chuk Chan, who's just terrific and provided lots of data for this. And so socioeconomic deprivation is clearly a big part of what's going on. And you can see here the risk of diabetes when one compares in purple those who are least deprived versus those in the kind of the orangey brown color, which is the most deprived. And you can see this huge difference. And of course, the proportions in each of these groups, on a population basis, you're more likely to be in one of these groups if you're Marae or Pacific than the other groups. And again, one has to think about that from the proportions that I'm going to show you. So I'm going to keep on focusing on renal because Kanchana, my PhD student, will be talking next on video, and she's really focusing on the renal side because the renal side is something that is really very, very different between Marae and Pacific people and really many of the other, well, all the other groups really. And then this is the proportions in the people with diabetes who are on dialysis across all of the people with diabetes. Among Marae, about 1 in 100 are on dialysis, whilst in those of New Zealand Europeans, it's about fifth that. But how about comparing that with those without diabetes? Look at this. This isn't just 10 times. This is 20 times greater on accrued rate. That is, or age standardized rate. That's a huge difference, isn't it? So the dialysis, I don't know, how much does that cost per person besides all of its impacts on family and the person and the community? It's like what is it now? 80,000, 100,000? 120,000, all right? So this is huge and impacts on everything really, and certainly on those individuals and their families. And the thing that drives that is not just glucose, it's also blood pressure, and I'll take you through some of the evidence that we've generated. So this is the number of people with diabetes in Auckland Metro region, and this is the proportion with that protein that I mentioned before leaking through the kidneys as a flag that there's damage to the kidney. So of those with diabetes, it's around half of Marae and Pacific people, and it's about under a third for other ethnic groups. So this is a real predisposition. We need to understand why that is so we can look at what are the best interventions. The proportion with a high glucose is 1/4 of Marae and Pacific people, and it's less than that. And this is from 2022. This is quite recent data, still. It's like this. So we know that this is persisting, and so what Wing did, he took the people in 21 who had a high glucose with an HbA1c above 75, and he said, how many of these have remained high 1 year later? I mean, you'd have thought, this 75 millimole per mole, this is a really big risk for infection, for hospitalization. You feel people kind of adjust, but when you bring the glucose down, people said, we didn't realize how yucky I felt. Often do that. So it really is not a good thing. But if you look at how many this has persisted, it's 2/3 among Marae and Pacific people. Among Indian, Chinese, others, it's around half. So one has to say, well, why did it persist? And you can say, well, was this about access to care? Is it about medication prescribing? Is it access to things that aren't quite so new anymore, the SGLT2 inhibitors and new agents? And maybe it's about access to primary care, and you guys will know better than me. But to me, looking from somewhere in Australia where it's sometimes pretty challenging, 99% are basically enrolled with primary health care. I know it costs for a lot of people, but the proportion who had a contact in the previous year, again, is over 90%. So people do have access to primary care, That's certainly not the way that these numbers show, is it? Maybe it's not being able to attend as often as you want to. Are people receiving medication? This is the proportion that received any of the diabetes agents in the previous 9 months. So, it's about 85%. Usually about 10 to 15% will be on diet alone. So there's access to the medications. Perhaps they're not being picked up quite as much, but there's no ethnic difference in that at all. You see, it's the same proportions that are kind of picking them up. And then if we look at these new drugs, which are particularly empagliflozin and that group protecting kidneys and against heart failure and those other things, you can see that whether you're saying diabetes and people leaking the albumin with a high glucose, actually, marae Pacific people are more likely to be prescribed the SGLT2 inhibitors and GLP-1s. And that's really any category, whether it's to do with kidney disease, whether it's because they've got past cardiovascular disease and a high glucose, or heart failure, and the last H1C is also high. So this is not about a reduced access to these new agents that are so effective. And when we're trying to prevent progression of leaking of the protein to kidney failure, then we also use these ACE inhibitors. And again, there's no real difference in access to those if people have got the early kidney disease, the proteinuria. The proportion with the empagliflozin, again, is the same or more. So as you can see, just trying to dissect this out. So I've covered the differences in diabetes prevalence and differences in glycemia. And it looks as though the differences in diabetic kidney disease, they don't seem to be due to access to primary care, access to medications for glucose or for the kidney damage, or access to new medications. So there are other things going on, aren't there? So we're fortunate that we've got the data that we had for 25 years to help. This is before the new medications came in. And part of the reason that the new medications came in, if you press on the Pharmac website, you press on that, and this paper comes up, which within 2 weeks, was it within 2 weeks of this coming out, then Pharmac made these medications available. The funding of this is Candice Manukau Health and Middlemore Foundation, and we thank everybody who's involved. So 79,000 audits with diabetes. In fact, we've got 130,000 in the whole database. I'll put type 1 diabetes to one side, but if there's time, I can comment on that. So almost 47,000 people with type 2 diabetes. How much? Am I there? I'm well over. I've only just started. Okay, I'm going to jump over this because that's irrelevant. That's what's been happening over time. But I do want to, I do want to just say this is really a key number. So the number here is the age at onset, at least age at diagnosis, which is probably closer to age at onset in many ways. So for those who are New Zealand European, it's 62. For marae Pacific people, it's 10 years younger. There's 10 years more exposure to diabetes. There's 10 years more of those kidneys being damaged. And this basically shows mortality. I'll jump over these because they're not necessary, but there's also a difference in natural history of what's going on. So if you have a look, this is any kidney disease. This is kind of minor kidney disease. This is important, and there's no significant difference. What the difference is that marae Pacific people are much more likely to progress to severe kidney failure. So that's a big key difference. They progress. So there's something in the mechanism, and it's Pacific people as well. So why is this happening? And this is our 25 years of our audit, and there's no real difference in blood pressure, which has been a big driver. But there's been about an 11 millimole per mole or more difference in H1C for 25 years. There was until the new drugs, and we don't have that data. And green is European, and blue is marae, and red is Pacific. And you can see the proportion attaining their target. Europeans were much more likely to achieve their target within the 5 years, or still it's only half. But in fact, Europeans were less likely to achieve their blood pressure target. And that's blood fats. I won't talk about those. So this is, I think, virtually these are the last couple. That's all right. So this is looking at the disparities aspect in terms of the socioeconomic status as well as ethnicity. So if you look here, this is socioeconomic quintile, so every 20% of the population, and this is by ethnicity. And what you can see here is this is the reference. New Zealand, this is those who are least deprived. And you can see that as deprivation increases, here's the increased risk and this one's of excess premature mortality. And you can see the same for excess heart attacks, myocardial infarction. In terms of ethnicity, you see this huge difference of premature mortality among Maori. Asians have got lower premature mortality than Europeans, and here's Pacific and others. And here you've got myocardial infarction. In fact, it's New Zealand Europeans that have the highest rates. And if we, oops, there you go, get rid of those. That's the stroke, again, New Zealand Europeans at the highest rates. And here's that gradient in terms of socioeconomic side. But here's kidney failure, and here are Maori and Pacific people. Much, much more. So the complications are different between the different ethnic groups. And I think this is virtually the same paper, but I've just divided it. So it's all one table. What you can see here, it's quite complicated. This is when you've got ethnicity and you've got socioeconomic status or least deprivation to most deprivation here. And this is the reference. This is New Zealand Europeans who are in the richest group, basically. So they're there. When you see green, it means that they have a lower rate of premature mortality versus this group. So you can see that from a health perspective, Asians actually have got much less premature mortality. If you look at Maori, which there's no socioeconomic gradient, and it's almost double the rate of this richer group. So that's important. There is a bit of a gradient in Pacifica, but you see this group here, which are poor Europeans and obviously poor Maori and poor Pacific people, they don't get to the same levels of Maori, but I think this is part of the background issues going on. But you can see this is the impact of that deprivation, hugely more versus those who are, oops, there are those. So this is the end-stage kidney failure. Here's the reference. And you can see again, Asians got a lower risks. And you can see that when you compare in any line, so whether you be the second least deprived, Maori and Pacific people always have more, always. Oops, there you go. And then if we look at myocardial infarction, then it's actually Pacifica and Asians have lower risk when you adjust for everything like smoking and BMI, all of those things, lower rates of myocardial infarction. And Maori again have lower rates than New Zealand Europeans. So this is 34% higher, and that's the highest risk group, which are those in the most deprived quintile. So I told you I'd almost finished. So just to conclude, so social determinants of health are associated with the prevalence of diabetes complications. Socioeconomic status, the built environment, food environment, access to affordable quality healthcare and social context are all really important. But RCTs are really difficult. So these are very difficult things to get to, but they are possible. The medically tailored meals, the community-based approaches, health literacy, knowledge, improving knowledge, okay? So socioeconomic deprivation is, and I didn't show you this, is a bigger attributable fraction than ethnic differences for many complications. But there are differences by ethnic group. Access to primary care medications and new medications don't seem to explain the ethnic differences, particularly in nephropathy, in kidney damage. And the social determinants, excess in Europeans, but they don't appear to explain the ethnic differences in diabetes kidney disease or its prevalence. I'd like to thank the whole of the DCSS team, the nurses, the other team members, the auditors, and particularly Karen, who's been doing a phenomenal job. Patients and their whānau who generously allowed their data to be used in the audit, and the communities for their support. The executive group who are there, our funders. Daha is my statistician in the UK, who does lots of stuff. And for our Pacific Church program, that's our LTA team. And also just the opportunity to thank the Katiaki Rupu for helping guide us with some of the other research that we're doing. Looking at the Diabetes Care Support Service data and looking at those under the age of 40, and looking at, what are the differences with the data that we have that could explain the differences that exist in terms of nephropathy. Oh, that one's come up. And then project 3 comes from some samples when we were doing research previously, and we're looking at people without diabetes but are first-degree relatives of people who either had kidney failure, had diabetes and kidney failure, or neither. And these are younger people, they're in their 20s or younger. And when we did this study at first, we found that those with a family history of kidney disease were leaking protein into their urine already. And it was not related to their diabetes, their family history of diabetes. It was the kidney disease. So there's something going on in the kidney side. And so we've got those samples. We had the karakia over the samples. Thank you very much, Robert. And they're now being analysed for maybe looking at what's something called microRNA, looking at, what are the possible mechanisms that flag it. And we've got a few candidates looking at why is it that they're leaking protein more, have they got inflammation, those kinds of things. So we've got those things being analysed at the moment. So that's project 2. That's project 3, sorry. Project 4 is looking at the impact of weight loss on that kidney function. But that project 2, she's finished. And I think the one key finding, because when you're bigger, then the amount of blood going through your kidneys is more, and you do actually potentially have what's called hyperfiltration. So things are pushing through, and you can imagine you've got some soft tissue and you push through it, things aren't going to end well, potentially. So we thought that one of the reasons why Mayan Pacific people might have more kidney damage may be because of having a high BMI. That's not what we found. So there's something else causing it. So we're trying to, so that's a really important finding, and Ken Chan is writing this up at the moment.